What I'm setting up, I'd like to, since this is my first talk, I'd like to start by thanking everyone. Can you hear me? Yeah. First of all, congratulations to Professor Najia El-Abadi, who is a leader in neurosurgery, an example to all of us, not just the women in this room, but everybody. A superb meeting, and congratulations on your election to the Pan-Arab, following in the footsteps of Professor Al-Husseini. Congratulations on your successful term. And I want to thank Professor Germano, Isabel, for organizing this for the WFNS, this very worthwhile effort. I think the two most important things that we do are to take care of our patients and to teach. I think these are the most, I think, pleasant and satisfying thing for us. And thirdly, to be here in Morocco, again, a country that's such a beautiful country and such wonderful, hospitable people. I thank you once again for all of that. So, like you heard earlier, fantastic talks this morning from Professor Servadei, Bakhti, Germano, Asakir. It's impossible to, we have to be selective. So what am I going to talk about today when it comes to the cerebrovascular? So three things that are all focused on the area of revascularization. In other words, a problem with the vessel that is occluded and we want to reopen it. So the three areas are revascularization for ischemia, late and wake-up ischemia, a new, somewhat emerging field of idiopathic intracranial hypertension, and for aneurysms. So let's start with the ischemia, acute ischemic stroke. You know, most of what we do, what we focused on in neurosurgery is hemorrhagic stroke, because that's what demands the immediate attention, and usually ischemic stroke has not been something we focus too much on. But it's not because it's not a big problem. You've heard from Professor Servadei that we have to focus on issues, especially in this forum, that are worldwide, and ischemic stroke is a worldwide global problem. And it is a problem that needs to be solved, especially in the countries that you see here, other than in Europe and in the United States. The mortality from ischemic stroke is horrendous. So if you look at this statistic, the mortality of ischemic stroke outside Europe and the United States is 3 to 10 times what it is in Europe and the United States. So it's a very, very serious problem. It's a public health problem. We have failed up till now. All the studies in the past had failed in showing us what we should do for those patients. We've tried to open the vessels, and all the studies have failed in 2013. IMS3, Mr. Rescue, Synthesis, all of these have failed. Why did we fail? We failed because we did not have a very good criteria for revascularization. We did not know how to select the patients, whether we select them inconsistently. We did not insist on a technical good outcome, such as opening the vessel, or on determining flow criteria. So what has changed? The world has changed when it comes to vessel occlusion. It has completely changed. 5 studies that were published and that came out in 2015. You see them here. All of them show the dramatic improvement in outcome from revascularization. And if you look at a meta-analysis that looked at that, it's, again, very significant in favor of revascularization. In other words, large vessels that are occluded, that are reopened, and now we have successful outcome. Why do we succeed now? Because there is imaging criteria that are very stringent. We don't hold IVTPA, still give it, but then there are new devices, the stent retrievers in particular, or better suction devices, and more emphasis on workflow. As people use the Formula 1 analogy. When a patient comes in with an acute stroke, everybody congregates around the patient and helps take care of them. So it's a new standard of care. Right now, it's a class 1, level A evidence for patients that are come in with a previously good status and with an occlusion of the carotid or the M1, and you see all the criteria here. But even that is changing. 2 new studies, even more recent studies, that look at after 6 hours, 6 to 24 hours or 6 to 16 hours, the diffuse study and the dawn study are showing the same thing, that in patients that have good selection criteria, for example, look at this patient here, the area of stroke is small, the area of perfusion is much bigger. So there's a great area that's still at risk, and those patients can benefit from revascularization up to even 24 hours. So even for late presenting cases in countries such as yours, where patients may have to travel, all is not lost. Patients can still be sent to centers that have these technologies, and they can be helped with that. Switching gears now, revascularization for idiopathic intracranial hypertension. So idiopathic intracranial hypertension, previously known, or a lot of times still known as pseudotumor cerebri. You know the symptoms: headaches, papilledema, symptoms of visual loss, etc., and intracranial hypertension. What is the cause of that? What is now noted is that in a lot of these patients, there is a problem with venous outflow. If the blood cannot come out of the head, there is increased intracranial hypertension, and that could be the cause of the problem. So what could be the reason for that? When you have a stenosis, of course, you know that. This is some paper on hemodynamic modeling, but there's pretty obvious that when you have a blood flow that is constricted and cannot get out, the flow velocity increases, but if that's not enough, then the blood flow decreases. And when the blood flow decreases and the constrained space of the cranium, the intracranial pressure will go up. So you see here this patient. This is a series that we published of 5 patients. Here's an example. You see the stenosis of the sinus, and there's a pressure gradient from 24 to 47. If you look at the flow, the total jugular outflow of this patient, blood coming out of the head, is 440 cc's. What is the normal cerebral blood flow? It's about 700 cc's. Okay, so that means the blood that's going into the brain is not coming out through the jugular vein. That's a problem, of course. So where is it going to come out of? The facial vein, transosseous veins, all those things. So the intracranial pressure goes up. And when you stent that patient, the pressure gradient normalizes and the blood flow doubles. So what is the data in the literature? Multiple papers. I'll show some example. Stenting improves intracranial pressure. The graph speaks for itself, before, after. Stenting improves outcomes. Papilledema improvement, vision improvement, headache improvement, low complication rate. And how does it compare to shunting, for example? Much better. So the stenting, where it's indicated, has better symptom resolution and lower complication rate. And here's a patency, long-term. Again, 78% of patients in stenting alone improve with 100% patency rate. That's tremendous. Those patients don't have a shunt. So here's a case, again, from our series. Typical 28, 22, young person, obesity, headaches, papilledema, loss of perception of light, empty sella, all the signs of increased intracranial pressure. What's the problem? You see the stenosis of the sinus and the total outflow, 484, half of what it normally should be, as measured by the MRI blood flow. Here's the angiogram. You see the pressure gradient, 38 to 6, so there's a huge gradient, 32 millimeters of mercury, and when this stenosis is treated, the gradient disappears. And what happens to the flow? It improves from 484 to 663, and the patient's symptoms disappear. So at 6 weeks, complete resolution of headaches, acuity 20/60 when she was almost blind, and so forth. The last revascularization, so 3 topics, is aneurysms. Of course, now aneurysms are treated more and more with endovascular measures. What does that mean? That means the aneurysms that cannot be treated with endovascular measures are complicated, that will require revascularization. And when we treat them with revascularization, we are at risk of compromising blood flow in the vessels that are leaving the aneurysm. So we want to preserve the flow, and the way we do that is through a bypass that is a flow replacement bypass. It's not augmentation, it's replacement. And the way we do a replacement, it's either the traditional EC-IC bypass or IC-IC bypass. What are the take-home messages? 1, if you're doing a bypass, the first bypass you should learn is this one, then maybe this one, and later this one. And there's many reasons for that, but that's the basic bypass that should be mastered. The second thing is that flow measurements are very important if you're doing a bypass for aneurysm, because it's a surgery that is designed to correct for a flow deficit that we create during the surgery. There's no flow deficit before the surgery. We are causing this problem. So it's an algorithmic surgery, and if you calculate the deficit of flow, you can devise your surgery algorithmically in a manner that makes sense. I encourage you to read this paper about cut flow, what it means, cut flow index, what it means. We can talk about it later, and I'll have a couple of talks this coming days. An example, this lady, young woman with this aneurysm, it's a complex aneurysm because it's at the confluence of the P1, P2, and the PCOM. You cannot clip it. You have to be prepared for a bypass, which we are prepared for. But what to use? Which branch? The STA is the easiest branch to use, better than anything else. So here's the anatomy. Left side, pretemporal approach, cranial nerve second, the ICA, the PCOM, the PCA, and you see the aneurysm right here. We measure the flow and the PCA. 16 cc's, that's what we need to replace. So if we check the STA cut flow is 39, plenty enough to replace the flow, and we do the bypass, pretemporal, at the P2 level, we check the flow in the bypass. Only 5 cc's. Why? Because there's no demand. When we trap the aneurysm, the flow in the bypass will increase to 22, 23 cc's. So again, these are flow replacement surgery, and here's the flow being measured later. You see the bypass matures. It's now 70 cc's, and this is how you construct these surgeries. So very briefly, selectively, we looked at cerebral revascularization, which is an emerging field, old but also new. It's a new era. We've concentrated traditionally on the skills. We go to the lab. We do microvascular anastomosis. We take courses. That's important. It's necessary, but it's not sufficient. Today, you need to have a physiology-based approach for acute stroke and for the emerging field of intracranial hypertension and for bypass for aneurysms. And these are physiologically and based on flow measurements. So thanks again for the distinct pleasure of being here with you. And this is what our place looks like historically and today.